So, how we can safely intubate someone in the pediatric ICU? Briefly, we'll discuss in this video. So, we need to know what are the indication, whether indication is elective versus emergency. So, elective intubation is always safe because mostly in emergency cases, then you may not have a proper preparation. So, preparation is the most important thing because you need to prepare well, like oxygen, ambo bag, proper face fitting mask, and ambo bag should be connected to the oxygen, suction should be ready. Obviously, you want to use some medication for sedation, analgesia, or paralysis. So, everything has to be prepared. So, proper preparation, especially for the equipment, oxygen, suction, ambo bag is very important. Mostly, the important point which you need to remember that we have to intubate pediatric patient early, because if we intubate late someone, then maybe the prognosis is not good. And I have seen patients are delayed, sometimes very late intubation. So if someone has a cardiorespiratory compromise, especially like myocarditis, and they have a likely chance of dying if you delay the intubation. There are a lot of indication to intubate someone in pediatric ICU, like cardiorespiratory, neurological, or so on, or maybe just because of septic shock. But early intubation is always helpful in these patients. So prepare well. And also there is another slide which will discuss about the prepare mnemonic. And also there is a one stat application available, and which will tell you about the doses and the equipment used for patients. Anticipate difficult airway. There are plenty of assessment, clinical scoring available, like Lemon or Malapti score. But the most important thing, that what is your obvious assessment? If someone has a large tongue, a difficult opening in mouth, and receding chin, and also you can ask if someone has history of intubation before, because that is very important, because they might have difficulty in the past, and then you have to involve your other colleagues, including anesthesia, because the most difficult airway we have encountered in ICU, especially when you have very large tongue and small opening of mouth, and difficult to negotiate instrument within the oral cavity. And also you have to take ample history and very important events leading to the situation what you are dealing now. So allergies, medication, past medical history, last meal is very important to remember. So what we can do in these patients, medication, mostly in ICU, pediatric ICU, we use midazolam for sedation, like 0.1 milligram per kg, and we use fentanyl 1 microgram per kg, 1 to 2 microgram per kg, and you can use rocuronium stat dose like 1.2 milligram per kg, or if you have, you can use atracurium or cis-atracurium, and the dose is 0.3 milligram per kg. Mostly, especially in like Pakistan, we don't have cis-atracurium. We are using atracurium, which has a side effect of you may encounter lot of secretion after giving. So also cis-atracurium has an advantage of Hofmann degradation, and it does not need to be cleared by liver or kidney if you have a multi-organ dysfunction syndrome. But the important medication which you need to remember for the muscle blocker, you can use succinylcholine if there is no contraindication, or rocuronium, because they are quick in onset, and very quickly you are able to intubate your patient in the next 30 seconds. Also ketamine you can use in a patient who has asthma, and propofol you can use if you have a good blood pressure and if you have a traumatic brain injury patients. But a lot of times in developing countries like Pakistan, we don't have drugs available, so simply you can use in a small kid midazolam or a little bit dose of nalbuphine, which is painkiller plus sedative agent. So muscle relaxant we have available here atracurium, and the dose you can use 0.3 to 0.6 milligram per kg. Normally it takes 1.5 minutes to allow you to go in. So what is rapid sequence intubation? A rapid sequence intubation where you give drugs quickly and you do select maneuver, and you are worried about the patient may not aspirate the gastric contents. So I mean, the sequence in a rapid sequence we'll discuss quickly. So there are 7 steps, which 7 P's of intubation: prepare and plan, pre-oxygenate, pre-treatment, especially with the oxygenation and medication like midazolam, paralysis, or you may want to induce through gases. Protection is very important, especially spine and positioning depending on the age. And also, once you are intubating a patient, you have to do the select maneuver. You have to compress the upper part of esophagus against the posterior spine by putting a finger on the middle of your neck. And you have to put, the placement of endotracheal should be, you can see through cord, the tube is going through the cords. And post-intubation management is very important once you successfully intubate. So there is a mnemonic for preparation before intubation, like prepare. So with the P, as we discussed before, pre-oxygenate position, do not remove oxygen, increase supplemental oxygen, and align the patient airway axis. Reset, especially the frequency of vitals, do not prematurely lie the patient flat, empty the stomach, examine the airway, identify the cricothyroid membrane, avoid the poor commands, and escalate escalate things as it goes on. So plan, you have to devise plan A or plan B, identify, announce, share plan A or B, and ensure it is the right plan. And also you have to gather your right equipment and right personnel. Adjust the anesthetic agent if you are using, mostly we are using the medication like midazolam, fentanyl, plus any kind of muscle relaxant if there is no difficult airway. And never ever give muscle relaxant if you suspect the patient has a difficult airway, and be ready with your air adjuncts in case of difficult airway and anesthesia on call. Also, you have to review. Do not leave the patient prematurely. Perform head to toe review, and also announce future concern if you are planning something more. Also, you can exit, announce when you need to change the plan, coordinate, and also you can debrief your entire team. I think the most important thing before intubation for any patient, you need to have proper equipment, and oxygen source should be attached to your ambo bag, and your bag should be appropriately working, especially if you have a flow inflating bag. Mostly we are using self-inflating bag, and also the self-inflating bag should have a proper face-fitting mask available. Sometimes the mask, if it is, the smaller mask cannot work. If you have a larger mask, you can apply by reversing, and there will be good seal. Always remember, in intubation, if you are using larger blade, you always can come out, but don't use smaller blade, because then you cannot go inside. So if you are using larger mask or the larger endotracheal blade, there is no problem. You can always improvise. Important consideration, if you suspect airway, you have to suction, bag, mask, ventilation should be appropriate, and you should be fluent, and there should be chest rise, and there should be change in vital. So the most important thing is the pre-oxygenate well, and do bag, mask, ventilation. And even in between repeated attempts, whenever your saturation is going less than 80, so you have to take patient on bag, mask, ventilation. You mostly were using straight blade, but if the tongue is big and older kids, you can use the curved blades as well. Less than 4 year, we are putting uncuffed tubes, but always there is no exceptions. If you know that patient has a significant leak because of poor compliant lung, so you can put a cuff tube. And even if you can put a cuff tube, we know that whatever the tube we are calculating, we have a simple calculation, age plus year divided by 4. Suppose if the age is 1 year, you get 17 divided by 4, 4.5. So if you are putting cuff tube, you put less than, 0.5, less than what you have already measured. Like if your uncuffed tube is 4.5, you can put a 4 size cuff tube, and even you cannot, you don't inflate the cuff if you think you can ventilate without inflating the cuff. But if you have a difficulty in ventilating, especially the leak, then you can inflate the cuff with the air. The most common mistake here, especially in the developing world, we are doing that a lot of times patients, they are not attached to cardiac monitor while you are intubating. So make sure your cardiac monitor is on board, patient is attached, you can see the rhythm, oxygen saturation, and also you can see the blood pressure. So check proper endotracheal position after intubation, like in the form of missed change in vital, air entry, and also there should be improvement in the vital, including oxygen saturation. And the most important thing is the end-tidal CO2. You can use the disposable or you can use the permanent one, which is connected to your monitor, and that's the most reliable method of checking the tube is appropriately placed or not. Also, you have to secure the tape yourself before you leave patient to the nursing staff. And if the baby is small, like less than, it's like newborn, the formula for the taping is 6 plus weight. Suppose if the newborn has a weight of 3, then you should tape at 9. This is for the lip. And if you have like infant or child, whatever tube you have put, you can multiply with the 3. Suppose if you put 4.5, you can, tape your tape at like 12 or 13. And don't forget to call for X-ray. Thank you very much.